This is Neurology Recall, a collection of our most useful, practical, and educational podcasts on a wide variety of topics selected from our neurology podcast collection. Whether you are new to neurology and training or have been practicing for many years, Neurology Recall is designed to help you continue to learn the essentials of neurology, easily, one podcast at a time.
Hi everyone, it's Jeff Ratliff, Deputy Editor of the podcast, coming to you from Thomas Jefferson University with the March 2023 Neurology Recall. This month's Recall is a collection of recent interviews we've conducted about topics in neuro-oncology. The first interview you'll hear is with Johan Koekkoek, interviewed by Haley Alexander about choosing anti-seizure medications in patients with gliomas. That aired on September 26, 2022. After that, you'll hear my interview from April 14, 2022, in which I spoke with Colman and Kelly Fritz about the availability of Lomustine for patients with GBM. In the third interview, you'll hear Stacey Clardy interview Oliver Tobin about histiocytic diseases that affect the central nervous system. That interview is on the August 18, 2022 episode of the podcast. Closing out this month's recall is an interview in which Derek Stitt spoke with Rachna Malani about immune effector cell-associated neurotoxicity syndrome, or ICANS, in patients receiving CAR-T therapy. Even if you don't primarily treat neurologic malignancies, we've pulled together interviews that are still relevant to the practicing neurologist to help identify and help with the management of the malignancy-associated topics we discussed here. Thanks for listening to the Neurology Recall, and have a great month.
This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening, and have a great week.
Hello, this is Haley Alexander from Wake Forest University, and today Johan Koekkoek is joining us from Leiden University Medical Center in the Netherlands. And we're going to talk about his paper that was recently published in Neurology titled Effectiveness of Antiseizure Medication Duotherapies in Patients with Glioma. Johan, thanks for joining us today.
Thank you, Haley. It's a pleasure.
Now, in your study, you looked at the efficacy of levetiracetam plus valproic acid as a duotherapy combination and compared that to other duotherapy combinations, which included either levetiracetam or valproic acid, but not both together. So what did you find?
Levetiracetam and valproic acid is a better duotherapy combination in terms of efficacy compared to other duotherapy combinations with either levetiracetam or valproic acid. And we found that treatment failure due to uncontrolled seizures was lower in patients who used a combination of levetiracetam and valproic acid compared to those who used another duotherapy combination. The other thing that we found is that patients in the other AD duotherapy group had a significantly higher risk of having a recurrent seizure. And what we did is a retrospective observational cohort study, and we looked at effectiveness. And effectiveness is, in fact, an outcome measure that includes both efficacy and tolerability. So efficacy is, in fact, the ability to achieve seizure freedom. Tolerability includes the frequency and severity of adverse effects. And regarding the methodology, it's good to note that patients with a glioma that we investigated often have a very poor prognosis, and therefore we used a so-called Cox proportional hazard model to take into account the competing risk of death, as patients who have died can no longer experience treatment failure or non-retention to a certain AD. Death is considered a competing risk in this population. And by using this competing risk model, we made a correction for the occurrence of death.
It's interesting because for most neurologists, I don't think we normally jump to valproic acid as being our second choice of anti-seizure medication therapy, especially now that we have several other newer generation anti-seizure medications available. So is there any theory mechanistically as to why this combination would be more effective in glioma patients?
So yes, there is indeed some evidence from preclinical models that show that especially the combination of levetiracetam and valproic acid leads to an enhancement of anticonvulsant effects and was better than compared to other anti-seizure medication combinations. And this suggests a beneficial synergistic effect which is in fact an interaction effect between two drugs that results in a joint effect that is greater than the sum of the individual effects of each drug. And the idea is that levetiracetam modulates neurotransmitter release through binding of synaptic vesicle protein 2A in the brain, and that affects the GABA neurotransmission. On the other hand, valproic acid is thought to have multiple mechanisms of action, including glutamate inhibition and blockage of sodium and potassium channels. So the idea is that this is indeed a very relevant combination. And in general, it's always the idea in the treatment of patients with seizures to go for so-called rational polytherapy, which means that it's always best to combine two antiseizure medications that have different mechanisms of action.
I seem to recall that when I was training, there was some thought that valproic acid might have some anti-tumor properties and therefore might be best to use in glioma patients. Is that still something that is believed today?
Yes, there have been some retrospective studies on this issue and on the possible positive effect of valproic acid on survival. But the latest years, we're just coming back to that idea. And there has been a very large study combining anti-epileptic drug use from major clinical trials in glioma patients that was published about 5 or 6 years ago. And that showed that, in fact, there was no real effect on survival in patients who were or on valproic acid or on levetiracetam. So, in fact, no, I don't believe there is a real anti-tumor effect of this agent, no.
Now, valproic acid is not our cleanest anti-seizure medication, meaning that it certainly has a risk of intolerance due to side effects, as well as possibility for drug-drug interactions. So in this study that you performed, what did you find in terms of the tolerability of this combination?
So what we found in our study, interestingly, is that we did find comparable tolerability of the combination of levetiracetam plus valproic acid versus other duotherapy combinations. However, in patients using valproic acid together with another AD than levetiracetam, we observed much more treatment failure due to adverse effects. And the most common adverse effects that we observed were related to myelosuppression, so particularly thrombocytopenia. So in that subgroup, we indeed saw that patients on valproic acid did worse in terms of adverse effects.
I see. So valproic acid is a good choice for these patients, but when used in combination with levetiracetam.
That's correct, yes.
And now I want to back up a bit because I was not aware that we actually had any data to support a best first-line anti-seizure treatment in glioma patients. So do we have data that levetiracetam is the best first-line treatment for these patients?
Well, actually, we do not have any good quality randomized controlled trials in brain tumor patients with epilepsy on what's the best anti-seizure medication. But the most evidence that we have comes from retrospective series. And indeed, those series points toward levetiracetam as one of the most efficient anti-seizure medications. So one of the advantages is it is efficient, it can quickly be started, it has relatively few adverse effects. And we also know that it does better than valproic acid monotherapy in terms of efficacy. And still, there are some concerns about levetiracetam, especially due to its neuropsychiatric side effects, or its as irritability, depression, psychosis. And therefore, it is recommended to be cautious, for example, in patients with frontal lobe tumors to prescribe levetiracetam. And there are also some other good choices, such as lacosamide and also lamotrigine. But interestingly, when we asked our colleagues a few years ago in the Neuro-Oncology community which antiseizure medication they preferred, there was an overwhelming majority of about 80-90% of the colleagues who said they put levetiracetam as a first choice. I think for now, levetiracetam is also my favorite, yes, as monotherapy.
Assuming there are not any real contraindications to starting levetiracetam, that is a good medication to consider first. And then based on your study, if the patients are continuing to have seizures and you've maximized the levetiracetam, it makes sense to consider valproic acid as the next medication to add to the levetiracetam. So do you have any other pearls about treating seizures in glioma patients?
I have to make one important note because it's a very interesting population of patients that we're talking about. It's patients with glioma, which is cancer, but also a brain disease. And we know glioma is a devastating disease with sometimes a very limited prognosis. We know, for example, that patients with glioblastoma, with grade 4 tumors, they have a median survival of about 1 to 1.5 years. And they can have many symptoms, including epilepsy. And therefore, it is so important to achieve seizure control as much as possible, to maintain also patients' quality of life as good as possible. And still, there are so many things that we still don't know about the complex interaction between epilepsy and brain tumors due to anti-tumor treatment and recurrent tumor growth. Glioma is a disease that has a constantly changing effect on the brain, which leads to different risks of developing seizures during the course of the disease. And I believe that when we want to prevent seizure recurrence better than we do now, we have to gain more knowledge on why seizures do occur at certain time frames during the disease, for example, at tumor recurrence or at the end of life phase. And if we can identify the period that patients are at real risk, we will eventually be able to better help them.
Excellent. And we look forward to seeing some more of your work in that area in the future.
Thanks for having me. And it was a real pleasure to share my thoughts on this manuscript with you.
Again, I've been speaking with Johan Koekkoek about his recent publication in Neurology titled Effectiveness of Antiseizure Medication Duotherapies in Patients with Glioma. You can find the full article in the September 6th issue of Neurology.
Hi, it's Jeff Ratliff with Thomas Jefferson University and the Neurology Podcast. For this week's What's Trending interview, I'm speaking with Howard Colman and Kelly Fritz from the Huntsman Cancer Institute at the University of Utah. Howard is the co-leader of the Neurologic Disease Center at Huntsman, and Kelly is a clinical pharmacist at the Huntsman Cancer Institute. Both of them are involved with the management and care of patients with glioblastoma multiforme, along with other neurologic cancers. We've invited them to teach us about a recent change in the landscape of GBM treatment and clinical research. In addition to other articles you may have seen in the press, there's an article in Neurology Today from September 16th, 2021, that was titled, "A Glioblastoma Drug is Abruptly Withdrawn from Medicare That is Not Good for Research Trials, Neuro-Oncologists Say," and that article is by Lola Butcher. To set the context a little bit for our listeners, in 2013, drug company NextSource acquired the rights to manufacture the drug Lomustine, which is a drug indicated for the treatment of GBM. NextSource went on to be the sole manufacturer of Lomustine until today. In early 2021, Lomustine was withdrawn from Medicare, creating a whole brand new situation for both clinical care as well as clinical research in the realm of GBM. So we brought Howard and Kelly to the podcast to teach us a little bit about the details of what happened with Lomustine, as well as its implications for patient care and research. So Howard and Kelly, welcome to the podcast.
Thanks very much for having us.
Thanks for having us, Jeff.
Howard, I hope we can start with you. While we know there are clinical research implications with Lomustine's withdrawal, I want to start with more of an on-the-ground clinical implication. So for neuro-oncologists like yourself, what was the impact on clinical care that Lomustine's withdrawal from Medicare had on patients with GBM, as well as for the neurologists who take care of those patients?
Thanks, Jeff, for having us on and for the question. Yeah, this falls into a bigger topic of financial toxicity, particularly for oral chemotherapies for patients with cancer. And even when these drugs are covered by insurance, sometimes the copays that patients are responsible for are very high. But in this situation, what makes it even more difficult for patients is that for those patients on Medicare, the withdrawal of the drug from Medicare coverage means that there's essentially no insurance coverage for the drug. So patients are either responsible for paying the whole amount of the drug themselves each month, or in some cases, looking for options for financial assistance, either from the company or other sources. But they essentially have no options for insurance coverage of the drug under Medicare.
And just to follow up, for those of us who don't do a lot of the management of primary gliomas and GBM, is Lomustine commonly used? Or I guess, as best you can say, what's the sort of scale of impact for patients who maybe previously were able to access it as part of their regimen and then those who all of a sudden could not?
Lomustine is one of the older drugs that's been used in treatment of primary brain tumors for many years. So it's rarely a first-line treatment these days. There are other chemotherapies like temozolomide that are typically the first line, but it's a very common drug used for second and third line treatment in glioblastoma, as well as other types of gliomas, and in some cases, other primary brain tumors. So it is a drug that many patients end up taking at some point during their disease course.
So certainly creates a new limitation on what patients can get access to in the care for their GBM. And switching to you, Kelly, I'm hoping you can teach us a little bit more about some of the backstory itself. And so in that Neurology Today article that I mentioned, they talk about that even before Lomustine was pulled from Medicare, there were price increases of Lomustine that we've certainly seen in other similar situations where drugs, often for somewhat rare diseases, have only a single manufacturer on the market. And often in those settings, we see that the price increases over time. Can you teach us a little bit about what was going on with patients' ability to access or afford Lomustine treatment, even in the years leading up to 2021? And then what changed with regards to the Medicare availability?
So Lomustine is an old drug, like Howard said. It was originally approved by the FDA in 1976. And Lomustine is not without its challenges in terms of drug shortages. So due to shortage issues, Bristol Myers Squibb, who previously manufactured it, actually had a lot of issues with shortages. So in 2013, they stopped manufacturing it. And that's when NextSource actually took it over and became the sole manufacturer and rebranded it under a new brand name. During the rebranding, they actually increased the price. So let's say a course of Lomustine was $200 for a patient. That's once every 6 weeks. It was increased to about $300 or $400 every 6 weeks. And since then, that cost has increased exponentially. And what we're seeing now, especially with NextSource not having approval through Medicare for these patients, it's around $2,000. So it's a huge increase in price just since 2013. That it's obviously not due to shortages now because we have one manufacturer that can actually get the drug out to patients. So it really is, like Howard said, a huge financial burden to our patients.
Wow. So, initially doubled with the rebranding in terms of price, but now a tenfold increase in terms of that price for this drug, which, as Howard said, is not uncommonly used. Howard, we talked about the clinical implications of Lomustine's availability and the pricing, and we know that GBM is often a devastating diagnosis and that our ability to treat it well today, but also in the future, is really increasingly dependent on finding newer and developing newer effective treatments. So what have the implications been for clinical research in the realm of GBM with this change in Lomustine's availability through Medicare?
Yeah, so even though this is an old drug, it is still important in clinical research and clinical trials in the sense that the standard way we determine whether a new drug is effective is by comparing it to an old drug. And so the later stages of clinical trials are often randomized trials where patients are either randomized to get the new, more innovative, and hopefully more effective treatment, but also patients are randomized to a control arm so that there's a clear comparison that allows us to tell whether a new treatment is better or worse than the old treatment. And in that situation, CCNU or Lomustine is often the control arm for recurrent glioblastoma trials or recurrent high-grade glioma trials. And so we have a number of trials, modern, innovative trials, but where the control arm is still CCNU. And listeners may not be aware, but in the way drug availability and billing occurs in a clinical trial is that anything that is new for that indication or isn't FDA approved is provided free of charge to the patient. But if the trial includes a standard drug, either as part of a combination with an experimental drug or as the control arm, standard drugs are billed to insurance as standard of care. So that means that unless the trial is providing the CCNU, patients who enter the trial and get randomized to the CCNU arm or get randomized to an experimental arm that includes CCNU, if they can't pay for the drug or if insurance doesn't cover the drug, that means they potentially can't participate in the research. So that's bad for the patients. And it's also bad for the field because we need solid controls to be able to determine whether new drugs are really effective and better treatments for patients. And if we have patients constantly dropping out of our trials because of the financial cost of the standard drugs, that raises difficulties in interpreting the results of the study and increases the chances that we might make some mistakes in interpreting the effectiveness or lack of effectiveness of a new drug if we don't have really good control data from patients getting the standard therapies.
And so in terms of the impact over these past 12 months, are there trials that are in limbo because of this? Or are there trials that had to halt enrollment of patients who are on Medicare? But what were some of the boots on the ground direct impacts to trials and protocols that were already in place?
Right. Yeah. So this is a recognized issue. And so different trials have taken different approaches. There are some trials that have basically purchased the drug and provided it to make sure all patients can get it. In other cases, there are options. So, for instance, one trial, Lomustine was the control arm, but if patients aren't able to get that, they're able to get an older IV version of the drug instead. So there are two drugs that are options there. So there are ways to work around it, but none of them are ideal from the patient standpoint or from the trial design standpoint.
Sure, to sort of change the protocol or to have these disruptions right in the middle of the trial. Kelly, you were talking a little bit before about the drug price increases with Lomustine, and I mentioned this phenomenon of single manufacturer drugs for rare diseases being at risk for rapidly rising prices that put a strain on patients and their ability to afford treatment. And Howard mentioned the concept, which we've talked about on the podcast before, of financial toxicity. Can you speak a little bit more about big picture issues related to these types of drugs and Medicare coverage? Is the story of Lomustine one that we're going to see in other specialties or subspecialties in neurology? And why might that be?
I think this is definitely not a oncology problem. I think there's a lot of non-oncology medications that we're seeing this happen to. I think the first principle is really what these manufacturers and what these drug companies can do for patients. And so usually they have some sort of program, whether it be a copay assistance or a true patient assistance program. So whether you decrease the patient's copay at the pharmacy or for the clinic encounter or the infusion room versus a true patient assistance, which is absolutely free drug. Typically, Medicare patients, just because they have federal insurance, are not eligible for copay assistance, whereas the patient assistance they can get. The problem is to get true patient assistance, as it is with Lomustine, you have to submit a lot of financial paperwork, tax information, your income, any expenditures that you have for the year. And it's essentially a lot of information that the company wants to know to see if you truly qualify for their free drug. And that's, again, we see a ton of it in the oncology space just because we are seeing so many new medications, and these medications are exorbitantly expensive. We get frustrated about a $2,000 copay for Lomustine, whereas some of these other oral targeted agents can be $10,000 to $15,000 a month. So I think there's this huge span of what these medications can cost and what the patients have to pay for. I think the problem is that these Medicare patients, again, usually are not eligible for a big piece of what the manufacturer has to offer. In Lomustine's case, since it's an old drug rebranded, it sort of falls in this weird category. All these new drugs that come out, most of the time, there's nothing else like it. They're novel medications. These companies do have plenty of copay assistance or patient assistance available, but with these old drugs, we're not really seeing the same benefit or the same robustness of these programs. So that part is a little frustrating as a pharmacist in a neuro-oncology clinic. I think big picture wise is that application to these programs takes time. Being qualified for a copay assistance program is pretty fast. It's just whatever insurance you have. Whereas the patient assistance, like I said, you have to fill out a lot of paperwork. And then the company decides whether or not you qualify. And then they usually contract with a special pharmacy that sends it to the patient. Really, it's like these older drugs that we're having problems with. I think some of the newer medications, maybe in 20 years, will have the same sort of issues. But these old drugs like the Lomustine and even starting to be temozolomide, we're starting to see more of these problems because either drugs are generic and just still expensive, or it's just that Medicare doesn't want to cover them.
I just want to add a comment here, which is that we're extremely fortunate and our patients are very fortunate to have experts like Kelly and other experts and support staff in our pharmacy group who specifically help patients with this process in terms of figuring out what are the options for copay or drug assistance and helping them with the application and knowing all the details of the different companies. But that level of support isn't present for all patients at all institutions. So you can imagine how challenging or impossible this process would be without that expert help.
Yeah, and that's a great point, Howard. I think it's good for, I guess, non-oncology neurologists to at least know the medications that they prescribe and if there is some sort of assistance program, because I'm very familiar with all the oncology assistance programs, but not necessarily the rest of the neurology ones. So if you don't have access to a pharmacist or an amazing pharmacy technician, I think you really have to do that work on your own. And it's a lot of extra time that the provider has to put in to be able to get patients this extra support.
I think you're right with these last points that the systems that are in place for these drugs are putting up hoops to jump through for patients with or without the help of someone like you, Kelly, or a pharmacy technician who can help them with this paperwork, which I think we can all hopefully empathize with someone who is dealing with a cancer diagnosis or some other neurologic diagnosis. Going through this process, this financial audit process is the last thing they need to go through at that time. I've been mentioning earlier in our discussion this Neurology Today article that came out in September, and here we are, it's March of 2022. So it's been 6+ months since this article came out. And one of the things that was mentioned in that Neurology Today article was that in order to get back into the fold with Medicare in 2023, there was key paperwork that NextSource, the manufacturer, would have to file with CMS by January 1st of this year, 2022. And so I'll ask you, Kelly, are there updates on that? What's going to happen next with regards to Lomustine's availability for both patients as well as for the clinical trial research that Howard was talking about earlier?
I wish I knew what NextSource was thinking, and I hope they did apply, but I actually don't have any additional information on that. You know, I talked about patient assistance programs, and NextSource actually does have a pretty robust assistance program. You still have to go through all the paperwork to sign patients up, but we have had good success, especially for our Medicare patients. They've actually been pretty quick. And by quick, I mean a couple days to 2 weeks. So not great in terms of if somebody's on a clinical trial and is randomized to that standard of care arm and needs to start on the day that they're randomized, but definitely an option for a lot of our patients who are not on trial. And like what Howard was saying, we have some options in the clinical trial landscape to use an older cousin drug of Lomustine if for some reason we can't get a hold of the Lomustine in a timely manner.
Got it. So I think for our listeners, it's important for those who are following this story, stay tuned to Neurology Today or other sources in the press that might give us an update on what may be down the road in 2023 with regards to Lomustine's availability beyond the current scenario that Howard and Kelly are navigating with their patients, as well as other neurologists out there who are taking care of patients with GBM. So I want to thank both Howard and Kelly for joining us. I've been speaking with Howard Colman and Kelly Fritz from the Huntsman Cancer Institute at the University of Utah about Lomustine and its withdrawal from Medicare as reported in the press, including a Neurology Today article in September of 2021. Thanks, Howard. Thanks, Kelly.
Thanks a lot.
Hi, this is Stacey Clardy. Today I'm talking with Oliver Tobin of the Mayo Clinic in Rochester, Minnesota, where he's a researcher and a clinical neuroimmunologist. I recently heard Oliver speak at the AAN Summer Conference, And his talk was on central nervous system involvement of histiocytic disorders. And it was one of those talks where I sat in the audience, and the more he spoke, Oliver, the more paranoid I became that I'm missing this diagnosis in some patients I've seen in the past. And whenever I get that feeling, I always think it's probably worth a podcast. So it really does seem to me to be a tricky group of patients to sort out. So Oliver, thank you for agreeing to discuss histiocytic diseases affecting the nervous system and everything we need to know to be certain we don't miss the diagnosis. Thanks for joining us.
Thank you, Stacey. This should be fun. Thanks a lot.
So how many histiocytic disorders do we need to know about as neurologists? And can they all affect the nervous system equally? Is it a central nervous system thing, peripheral nervous system thing? How do we sort them out?
So Erdheim-Chester disease is the one that most commonly affects the central nervous system in adults. And these patients typically have persistently enhancing brain lesions. This is the reason that they typically turn up to neuroinflammatory clinics. One clue to the presence of a histiocytic disorder is that up to 50% of patients have a diagnosis of diabetes insipidus. And the diabetes insipidus can precede the onset of other symptoms by up to a decade. And these patients will turn up with a diagnosis of idiopathic diabetes insipidus. A common misconception is that patients have to have bone disease. Now, it's true that patients with Erdheim-Chester disease have a very high rate of bony disease, but at least in my practice, most of this is not symptomatic. So if a patient does not describe bone pain or the patient doesn't describe something that you think may be related to bone, that doesn't mean that they don't have bone disease. And for that reason, and the fact that Erdheim-Chester disease tends to be a multi-system disorder, we perform a PET-CT scan of body from vertex to toes in all patients in who we suspect histiocytic disorders. The reason for doing a vertex to toes study is because the long bones are often affected, particularly the distal femur and proximal tibia. And if you perform a standard orbits to mid-thigh PET-CT scan, which is the typical type of PET-CT that's performed in general oncology studies, then you will miss this distal long bone disease that's very typical of Erdheim-Chester disease. The other disorder then, Langerhans cell histiocytosis, really presents quite similarly from a neurologic point of view to Erdheim-Chester disease. It's more common in children and it's more common in younger adults than Erdheim-Chester disease. But it also gives parenchymal brain lesions, which are persistently enhancing and respond minimally, if at all, to steroids. So these patients will often have been treated with multiple immunosuppressive medications, possibly with a diagnosis of a neuroinflammatory condition before they come. And then Rosai-Dorfman disease presents quite differently in that these patients don't tend to have parenchymal disease, but they do tend to have compressive extradural disease. So these patients are often misdiagnosed as having a meningioma of the brain or spinal cord, or sometimes even compressing the optic nerve or eye. And they can sometimes undergo quite extensive resections because they can be quite infiltrative and cause a lot of compression.
Okay. All right. I think I've got it. That's a fantastic overview. Things to think about. And it's bringing to mind more patients. I love that tip about the PET scan. I'm sure we could have an entirely separate discussion about how you managed to get those PET scans approved through insurance, but maybe we'll leave that out for this time. So how common are these conditions in total? Do we even know? I know they're rare diseases, so do we have an accurate figure on that? And further, how often do they present in the nervous system initially?
Yeah, so these are rare conditions, and I don't think we have a great handle on how common they are. It's estimated that there are about 1,500 cases of Erdheim-Chester disease globally. The prevalence of Langerhans cell histiocytosis is much more common in children than it is in adults. I would say this is likely to be an underestimate. The interest in these conditions has expanded greatly in recent years, and our ability to treat these conditions has essentially been transformed over the last 5 years. And, for that reason, there's a lot more energy being put into identifying these patients. And I think that's a really positive thing because we have the technology to significantly impact on the course of the disease and even cure it.
Well, tell me more about that, because I'm certain I didn't learn about that in my training. So what are the treatments now versus what did we used to do? So
these conditions are by and large driven by activating mutations in the MAP kinase ERK pathway. And so in 2017, the first medication was approved for treatment of BRAF V600E mutated histiocytic disorder or Erdheim-Chester disease. So that's vemurafenib, and that's a pill that patients can take. And in patients who have BRAF V600E mutation, it can essentially halt the disease. As in many cases in neurology, if patients are significantly disabled, it may not reverse the disability, but it certainly halts the progression. But after that was approved, of course, there are many other mutations that have been identified and continue to be identified, with the number growing, almost on a daily basis. And there are other targeted inhibitors. So the most common one that we would use would be MEK inhibitors. So cobimetinib would probably be the most common medication that we would use there. But there are many other mutations that have been identified, such as CSF1 receptor mutation and many other mutations in the MAP kinase pathway that can be targeted by specific agents that are not necessarily developed for histiocytic disorders, but may be developed for malignancies such as melanoma, but have utility in these conditions. From the point of view of non-targeted therapy, more standard chemotherapy regimens such as cladribine can be used, or even radiotherapy for isolated disease, potentially things like compressive lesions of the optic nerve. And then more recently, intra-arterial methylene therapy has been tried in patients with ocular disease and brainstem disease with some good success from the team in Memorial Sloan Kettering, led by Dr. Eli Diamond.
Wow, this is really exciting. I always think about patients I've seen remotely in the past, and I do remember being a trainee, and there was a patient on neurosurgery many years ago who they threw everything at. And there's no doubt in my mind this is what he had. He did have the diabetes insipidus, young man, and I remember he responded to nothing. So hearing you say this is actually quite exciting. So what are the most common misdiagnoses you've seen in this patient population?
Well, I suppose the most common thing is just patients who are diagnosed with non-specific inflammatory central nervous system disease. And, I guess we have many patients like that who end up being immunosuppressed. They have some response, and so that gives the patient and the treating team encouragement to continue, but ultimately it really doesn't resolve the enhancing lesions and doesn't stop the progression. The other, I suppose, specific conditions, things like sarcoid, as I mentioned, meningioma and clippers is often made as a diagnosis. From the point of view of evaluation, there are some non-invasive tests that can be done, and particularly given the high rate of diabetes insipidus and bony disease and Erdheim-Chester disease, the PET-CT scan of body can be very suggestive of histiocytic disorders. And screening for diabetes insipidus can also be helpful, because if you identify that, at least you know there's a pituitary lesion there. It's important to note that 50% of patients with diabetes insipidus don't have neuroimaging abnormalities in their pituitary in histiocytic disorders. So you really need to do the biochemical screen to evaluate for that. And then, as with many other neurologic conditions, if you can identify a systemic target for biopsy, that tends to be better because you can get a larger volume of tissue and it's easier to get at with less morbidity. And along with doing the standard pathology evaluation, considering molecular genetics on the tissue, if histiocytic disorders is high in the differential, is recommended.
Okay, that's really helpful. So we should be able to tell our pathologist, hey, this is a patient where I want you to look for both sarcoid, but also perhaps a histiocytic disorder, and the pathologist will know what stains or molecular genetic testing to do. Is that usually your experience?
Yeah, I will say they're quite tricky. In particular, the central nervous system biopsies tend to be quite difficult to interpret, and they will often be reported as being non-specific inflammatory disease. And if the clinical scenario is very suggestive of a histiocytic disorder, we sometimes go ahead and do a molecular genetics panel anyway. And if that comes back with a very suggestive mutation, then that helps to clinch the diagnosis and also gives us the treatment. If we identify a BRAF V600E mutation on molecular genetics, that tells us this is probably a histiocytic disorder, probably Erdheim-Chester disease, and that the treatment probably best be vemurafenib. So that's usually the strategy that we employ. But a non-specific inflammatory biopsy is quite common, particularly for brain disease, but also for bony disease as well in patients who've had prior biopsies.
Okay, got it. And molecular genetic testing, you're talking about on the tissue, right?
Correct. Tissue molecular genetics testing.
So there's no mutation we usually find if we're going to try to do serum testing on someone who doesn't have an amenable lesion. Those sort of serum panels for genetic testing that are becoming more readily available, they don't tend to be helpful. Is that right?
BRAF V600E mutation testing is available, and that can be positive, but if it's negative, it certainly doesn't exclude the diagnosis. In my experience, you generally, even if that was positive, you'd probably still have to get the tissue anyway, to confirm it, and also to make sure the morphology and everything looked correct. For instance, to make sure it wasn't a melanoma or some other type of tumor that could harbor that mutation. So ultimately, I think for all of these patients, we do need some form of tissue. But it is possible that these serum and possibly CSF targeted genetic panels may be more helpful in the future. We have limited experience, I'll say, with them to date, and the rate of BRAF V600E mutation positive in cell-free DNA is relatively low. So it's certainly not sensitive enough to make a diagnosis.
Understood. And so that's really where that PET scan hopefully comes in handy. I assume that, those bone lesions that the patients may not even be aware of are fair game for that tissue testing as well.
Absolutely. They're usually quite easy to get at. Another kind of pearl, I suppose, with the bony lesions is that the BRAF V600E immunohistochemistry tends to be negative if the bone is decalcified before evaluation by the pathology team. So to ask your friendly neuroradiologist or orthopedic surgeon, whoever is doing the bone biopsy, not to decalcify the bone when they perform the biopsy.
Oh, wow. This is important stuff. This is great. I'm glad I'm learning all this. So with all that in mind, you talked about this a little bit in terms of what treatments are available. It's very exciting. Does everyone need treatment? So, for example, let's say, again, I'm going to take you back to one of the patients I recently diagnosed with Rose-Dorfman. I thought it was going to be sarcoidosis. We went after a lung lesion, and it was Rose-Dorfman. And that patient had had one prior episode of aseptic meningitis, but otherwise nothing now. We didn't find anything else on the scans other than the lung lesions. Does that patient need treatment or monitoring like you might do for pulmonary sarcoid?
Oh, that's great. So Rose-Dorfman is tricky. These patients don't tend to have parenchymal lesions. So, if they have relatively stable extraaxial lesions that are not compressive and not growing, it might be reasonable not to treat them. I'd say most of the patients would have Erdheim-Chester disease or Langerhans cell histiocytosis or a mix. And those patients really do need to be treated because the mortality and morbidity in patients with central nervous system histiocytic disorders is much higher than in patients with systemic or isolated pulmonary histiocytosis. We do have a series of patients with isolated pulmonary histiocytosis, and they tend to do quite well, often discontinuing smoking in those patients without any treatment whatsoever. The histiocytic disorder regresses completely. But in patients with parenchymal brain lesions, they do need to be treated. Your patient sounds tricky. Love to see the images and learn more about that case.
Well, you sure will now. So is there anything else we need to know or remember based on your experience seeing a lot of these tricky histiocytosis patients with neurologic involvement?
I think the main message is that if you see somebody with enhancing brain lesions that are not responding to immunotherapy, or if you have somebody with a biopsy that has non-specific inflammatory change, to consider histiocytic disorders. And the main testing to perform is a PET-CT scan from vertex to toes, and also to screen for diabetes insipidus in those patients. That would be the kind of headline message that's kind of in my mind as I'm triaging and reviewing patients coming in. And tissue, as you say, tissue is king from the point of view of diagnosis. So to aggressively go after tissue, I think is important.
This has been really helpful, Oliver. I'm sort of racking my brain now about any patient I've seen with diabetes insipidus or other less clear autoimmunity with any sort of suspicious lesion in the past. You've given me, I think all of us, a lot to think about, especially in these patients with challenging MRIs that don't look typical, where the lesions don't really seem to respond to immunotherapy. And I'm hopeful that some more individuals will get a diagnosis after learning from you today. Thank you.
Thanks so much, Stacey. This has been great. Really enjoyed it.
Hi again. I'm Derek Stitt. In this week's Neurology podcast, we're going to discuss an emerging clinical topic that's becoming increasingly relevant to the practicing neurologist, especially those who interact with cancer patients. And that's the potential neurotoxicity associated with CAR T-cell therapy. CAR T-cell therapy is an FDA-approved treatment for many types of hematological malignancy, often after more standard treatments are unsuccessful. However, neurological complications after treatment are a known risk. And given the increasing prevalence of CAR T therapy, any neurologist who practices where cancer patients are treated should be aware of this entity known as ICANS, or Immune Effector Cell-Associated Neurotoxicity Syndrome. To help break this down into what the neurologist should know, we've invited our expert guest, Rachna Malani, neuro-oncologist on staff at the University of Utah. Rachna, thanks so much for joining us today.
Thanks so much for having me. I'm excited to be here.
Great. To start out, can you give us a really quick background for our listeners who may be unfamiliar with the basic principle of how CAR T-cell therapy is administered and how it combats cancer?
Essentially, CAR T-cell therapy is a form of cell-based gene therapy wherein the genes inside T cells are altered so that they can seek and destroy specific cancer cells. They recognize a specific antigen. I like to think of it as a targeted attack by our immune system. In CAR T-cell therapies, T cells are taken from the patient's blood and are changed in the lab by adding a gene for a receptor called a chimeric antigen receptor, or CAR, which then helps the T cells attach to a specific cancer cell antigen. The most common indications for CAR T-cell therapy are liquid tumors, such as lymphomas, where we have a highly specific antigen to target, such as CD19. The first step in generating the therapy is to collect T cells. These are essentially removed from the patient's blood via leukapheresis. You separate out the T cells, they get sent to a lab, and then they're altered to add a gene for the specific antigen receptor. They're then grown and multiplied in the lab, and then they're going to be given back to the patient via infusion. Prior to the CAR T infusion, patients are first given chemotherapy to reduce the number of immune cells so as to then allow the CAR T cells a better chance to activate and find the cancer cells. There's at least 5 approved FDA therapies currently for CAR T.
That's quite a remarkable process from beginning to end. Even though these T cells are engineered to target cancer cells, collateral damage to healthy tissue can occur. Is that right?
We don't wholly understand, but we have a couple of different mechanisms that we sort of do think are contributing. One is, normal tissue does to an extent express some of these antigens. So when you are giving the CAR T-cell therapy, it's going to attack everything. So you get a response to normal tissue as well to a degree. Also, we are seeing is a supraphysiologic response, and you get activation and upregulation of various immune effector cells like macrophages and inflammatory cytokines. What exactly triggers that immune response, we don't fully understand, but we have a lot of ideas as to what's going on.
Thanks for that background. I think that helps set up what we're really trying to get into today, and that's ICANS, which again is Immune Effector Cell-Associated Neurotoxicity Syndrome. So can you tell us, when is ICANS most likely to begin after CAR T therapy?
ICANS can occur with any of the CAR T-cell products. However, the rates, the timing, and the frequency do depend on which CAR T-cell you actually do end up using and the disease you're treating. That being said, though, generally speaking, ICANS most often develops within 3 to 10 days after CAR T-cell administration.
I wasn't aware of that specificity to the different types of CAR T therapy, so that's good to know. Of course, other than the proximity in time to receiving CAR T treatment, what are the clinical signs that the neurologist needs to know that should make us suspect ICANS? And really, what's the spectrum of the disease severity that we can see?
Though ICANS is typically seen in the context of cytokine release syndrome, or CRS, it can actually independently occur of CRS. So you can just get ICANS sometimes. That being said, though, commonly you see a systemic response first, and then within 2 to 4 days of that CRS, you typically then see the development of ICANS. The spectrum of disease is actually quite broad and can be extremely subtle to detect in the beginning. The first signs patients clinically will present with are inattention and language deficits. In particular, the development of an expressive aphasia, which then become global, and patients can become completely mute. Symptoms are usually rapidly progressive within hours to a couple of days, so close monitoring and frequent neurologic examinations are imperative. It's a wide spectrum of disease that we see in clinical practice, and this can be from the mildly affected patient who who is disoriented with mild expressive or receptive language dysfunction to the patient who then develops decreased levels of consciousness, including the development of a coma or stupor, as well as seizures and elevated ICP. The American Society for Transplantation and Cellular Therapy has provided us with guidelines and scales for grading ICANS. So it's graded on a scale of 1 to 4, with 4 being the most severe. The grade is determined by clinical manifestation, largely based on 5 core examination assessments. One being an encephalopathy questionnaire, so where we're asking questions surrounding orientation, naming, following commands, writing, and attention. And this is then followed by assessments of level of consciousness, seizure, motor findings, and elevated ICP or cerebral edema. So based on that scale, you can then grade it from 1 being mild, where typically we see a little bit of inattentiveness, some disorientation, and a little bit of language difficulty, but largely the patient can still communicate, to a grade 2, which is more moderate, more impaired levels of consciousness, but they're still somewhat responsive to voice, but very slow to respond and quite disoriented, to grade 3 and 4, which are more severe, which are patients who are harder to arouse even to tactile or noxious stimulation, and those who also may be having seizures and significant language deficits. I think the good thing to know is that these symptoms are actually typically very reversible and typically resolve within 7 to 10 days of onset if patients get adequate management. A lot of these patients may end up in an ICU, may need to be vented for airway protection, and in some fatal cases, the cause of death has been primarily attributed to malignant cerebral edema. So there's a lot that can happen, and it's a pretty wide spectrum.
Given that spectrum of disease, what are your thresholds or recommendations for when to obtain further testing, such as neuroimaging or EEG in these patients? And is there ever a role for CSF, for example?
I think the threshold is extremely low for further investigation. So I think our neuro toolkit, which is our exam skills as well as imaging and EEG, are pretty imperative. And then at times CSF can be helpful too. The EEG should be done in pretty much any patient who develops ICANS. We want to be looking for not only changes representative of seizure activity, but also potentially for things that could suggest a more toxic or metabolic encephalopathy on the EEG. And then neuroimaging is imperative. So usually we start with a non-conscious head CT because you want to look for things like edema or maybe like an acute stroke. However, if you can, an MRI ultimately is the most helpful test, but not all of our patients are going to be stable enough for that test. CSF is not a universal part of the evaluation. The main indication for CSF exam is when we start to think about things that are differential, like disease or infection. So if you have a high suspicion that this may be progression of disease in the CNS, or perhaps they have a meningitis, then those are really the key indications to get that lumbar puncture.
For most patients who experience ICANS, what is the long-term prognosis? And even those who have only mild ICANS, can they, or have you seen them develop any persistent long-term deficits at follow-up?
Fortunately, with rapid recognition and prompt management, this is such a reversible complication of therapy. So most patients are not left with long-term sequelae from ICANS. There's not a ton of data out there, but there are small studies that have looked at patients, retrospectively who have received CAR T-cell therapy and who developed ICANS. Based on those small studies, we see that there's not really any significant neurologic deficit in the long term that these patients are left with. There have been reports of delayed Parkinsonism, actually with some specific CAR T-cell therapy, but it's quite specific and not representative of CAR T-cell therapy as a whole. So it's pretty reassuring.
So let's shift gears to management. Rachna, can you talk to us about how ICANS is treated once it is recognized, hopefully promptly, and how long is treatment often required?
So, these patients require intense neurologic monitoring and they need frequent neuro exams as just the backbone of any sort of assessment. You also need to have multidisciplinary care. You're working with your hematology oncology team, and you also may need to be working with intensivists, whether that be medical intensivists in the ICU or neurointensivists, because some of these patients are going to possibly need ICU level care. So that being said, steroids are truly the backbone of treatment for ICANS. The optimal timing, dosing, duration are not fully well established, but essentially, for those patients who have a grade 2 ICANS or higher, it's best to initiate steroids as soon as possible. Usually the short-term therapy won't interfere with the CAR T cell therapy, because that's the big fear, right? That you just gave this immune-based treatment. Now we're going to give steroids and dampen that response. But actually, short-term steroid use is not associated with significant alteration of the cancer outcome with therapy. So you shouldn't be scared to give the steroids at the end of the day. Usually the starting dose is Dex 10, and you dose that every 6 to 12 hours. And ideally, you try to plan to taper that over the next 2 to 5 days. Usually with that sort of therapy, most patients will have a rapid clinical improvement. Some patients will have refractory cerebral edema, though, and they are most likely going to need, in addition to your high-dose steroids, things like mannitol, hypertonic saline, as you would typically do for any sort of high ICP patient. The anti-seizure medication part also is pretty much universal. So in any patient who has suspected ICANS, you're going to go ahead and start that Keppra 500 milligrams twice a day usually. And a lot of CAR T-cell patients may already be on prophylactic Keppra. So if they're already on prophylactic Keppra, you're probably going to bump up that dose. And then you're going to titrate based on what you see on the EEG. There are some other immune-based therapies that are increasingly being used, but truthfully, they're more so for the CRS than just ICANS. So some of the drugs you may come across are drugs like tocilizumab, which is an anti-interleukin-6 receptor drug. However, that's typically only used in patients who have CRS and ICANS, not for ICANS alone. And there's a bunch of other sort of investigational therapies that are also being used, such as anakinra, which affects interleukin-1. There's also drugs like cetuximab, which also sort of blocks the inflammatory pathway. But the treatment for ICANS with these drugs isn't completely clear. And that's because a lot of these drugs just can't cross the blood-brain barrier as effectively.
Can you give us a little bit of background again about what CRS is and its relationship with ICANS?
Definitely. So CRS is a systemic reaction that's associated with increased levels of inflammatory cytokines, activation of T lymphocytes, macrophages, and endothelial cells. Its severity is associated with a couple of different clinical characteristics like disease burden, molecular design of the CAR, as well as the dose of the CAR T cell, though the latter is not the most well-defined. As we talked about before, there is a degree of antigen expression on normal cells. So essentially, that inflammatory response that happens is systemic because of that. It gets triggered by the release of interferon gamma by activated T cells or tumor cells. This interferon gamma then activates macrophages that then produce excessive interleukin-6, predominantly hence TOCI, tumor necrosis alpha, as well as interleukin-10. This then sets off a cascade of events where in cells that don't actually normally express things such as membrane-bound interleukin-6 receptor do so now and are activated along with a host of other interleukins and granulocyte macrophage colony stimulating factor, leading to effectively a cytokine storm of sorts. We typically see CRS anywhere from 1 to 14 days, with a median being about 2 to 3 days from receiving CAR T-cell therapy. And the duration is very variable. It does typically resolve within a few days, like 2 to 3 days usually, but also can persist for 2 to 3 weeks after CAR T-cell infusion. And typically you're going to see things from like a mild flu-like symptom to a more severe life-threatening systemic inflammatory response syndrome. ICANS will typically occur preceding the development of CRS. So any patient with CRS is at a heightened risk of developing ICANS and needs to be extremely closely monitored for the development of ICANS.
Just to clarify, CRS typically precedes ICANS, not ICANS precedes CRS, correct?
Correct. Yes. CRS is typically first and ICANS happens after that.
When is it too far out from exposure to blame ICANS for neurologic symptoms or signs that we can see under the umbrella of ICANS? What is that time frame where you think it's too far out and you really need to consider other factors just based on the temporal profile alone?
Probably about 2 to 3 weeks post-therapy, the ability to pin things on ICANS diminishes. So the 3-week mark is probably where you need to start thinking about other things as being the cause of the neurologic change.
Out of curiosity, I was hoping to get your comment on what the landscape looks like for the role of the neurologist in guiding the treatment and workup for these patients who experience ICANS, because of course they're going to be under the care of a treating hematology or oncology team. And as an example, in my own practice here at Mayo, Mayo, when I encounter these patients, the hematology teams who are administering the CAR T therapy, they're quite protocolized. And oftentimes by the time that I'm on board, treatment has already been started, empiric steroids, Keppra, and if they've had CRS, then tocilizumab. I wondered, is that what you're seeing is the typical situation for the landscape, or have you seen where neurologists are more or less involved?
Across the nation, there are efforts at most centers to kind of protocolize this treatment for ICANS because early initiation of therapy is thought to portend a better outcome. So I think across the nation, there are more and more protocols being utilized by the hematology oncology team. That being said, your role as a neurologist can't be understated. These patients are highly complicated neurologically, and I think that our ability to help assess them with our exams and with our additional investigations really helps patient outcomes in the end. I can tell you from my experience, so I just transitioned to University of Utah from Memorial Sloan Kettering, and there, every CAR T patient has a baseline neurologic exam done by a neurologist. They're typically seen 3 times a week by the neurology team. And then if there's a change, neurology is paged, but much like Mayo, treatment may already be underway. And then from there, it's a real discussion about, is this really ICANS? And then in terms of steroid dosing, timing, all of that. So neurology really guides that part of things because there's still a differential to be considered, right? And I think we touched upon this a little bit earlier, but there are other things you want to make sure you're not missing, like an intracranial hemorrhage. Are you missing a stroke? Is the patient in status? Could this actually not be ICANS? Is this maybe, RPLS or PML or fludarabine toxicity? Fludarabine being one of the chemotherapies the patient may have received as part of their lymphodepletion for CAR T-cell therapy. So your role as a neurologist is actually extremely important in helping guide the management of these patients.
Thanks so much, Rachna. I was hoping that before we go, you could help me just review those high-yield pearls again for our listeners. So first thing I was hoping you could help just summarize again is, when should we suspect ICANS after CAR T therapy, and what are the most helpful signs to look for?
Typically think about ICANS 3 to 10 days post-CAR T-cell infusion, especially in the setting of a patient who has CRS. Be on the lookout for the subtle changes in mental status exam and the language exam. So just really think about disorientation, inattentiveness, and aphasia as well.
And then when we're seeing a patient with suspected ICANS, remind us about additional testing and what's the threshold to perform more testing like imaging and EEG.
Always have a very, 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 very low threshold. And I would personally just reflex to neuroimaging and an EEG, whether that's a spot EEG or continuous, but definitely get some form of EEG on the patient.
And then CSF in more select cases if you're also considering progression of the neoplasm or a CNS infection, right?
Exactly. If a patient isn't progressing how you expect them to, then I think you start to really think about the CSF exam.
When do patients with suspected ICANS need to start treatment, and what's the typical prognosis for those who experience the condition?
Start treatment right away. Right away. Even if you just think it's potentially what's going on, it won't hurt to give them a dose of Dex because the sooner you give it to them, the better the outcome is going to be. And unfortunately, this is a very reversible toxicity.
This has been awesome. Rachna, we really appreciate you joining us today to enlighten us on this really important topic.
Thank you so much for having me.
Well, thanks to everyone for listening. That's all for today. I'm Derek Stitt for the Neurology Podcast.
This is Stacey Clardy, your podcast editor. Thank you for listening and for letting us join you on your commute, while you're exercising, or even while you're brushing your teeth. This has been another episode of the Neurology Podcast, your best source of practical, relevant, and timely information for neurologists, clinicians, and patients. The views and opinions of the participants in this podcast do not necessarily reflect those of the journal Neurology or the AAN. Disclosures of the participants are included in the show descriptions, reached by a link on the neurology.org website.